Hi, I'm Nick and I'm going to talk about the differential diagnosis based on the clinical history and physical examination. First one will be congestive heart attack. It can be proven by the high examinated blood pressure, relatively high pulse rate examinated, and high breathing rate examinated. Not only that, patient also suffering from shortness of breath, distended jugular veins, and also has a history of heart diseases and heart attack. The high blood pressure and relatively high pulse rate, and also distended jugular veins, full and equal radial and femoral impulse also leads to the symptoms of hypertension. Anemia could also be a possible outcome due to the lethargic and pale in skin color and also shortness of breath. Lastly, chronic kidney diseases and liver dysfunction could be diagnosed due to the distended abdomen, palpable lower liver position, and also edema occurring in the patient. Now we are going to talk about the laboratory results and abnormalities. First one will be positive stool guaiac test, which may be a sign of colon cancer, gastrointestinal tumors, and also inflammation. Following by high creatinine level, which indicates blocked urinary tract, kidney problems, and also dehydration. The BUN level is also very high, which may be a sign of kidney dysfunction, dehydration, and also suffering from a recent heart attack. Next up, we have a high calcium level, which may be caused by kidney stones, excess vitamin K, and also hyperparathyroidism. High BNP level may be a sign of heart failure. The low red blood cell counts prove that there might be deficiency in iron nutrients, blood loss, low kidney function, and also anemia. Meanwhile, the low platelet count may be caused by immune thrombocytopenia, hemolytic uremic syndrome, and also certain cancer. In the blood smear film, the red blood cell size is observed smaller than the normal red blood cell and may be a sign of anemia. The abnormalities in the arterial blood gases proving that the body is taking not enough oxygen, carbon dioxide is not emitted, patient is suffering from shortness of breath, and also the accumulated CO2 in the body is causing the body to become acidic. Risk of colon cancer and lung cancer is shown by the high tumor marker test result. Sinus tachycardia indicating that there might be occurrence of damaged heart muscle, anemia, and also dehydration. Non-specific ST changes may be caused by congestive heart failure, ischemic heart disease, or left and right ventricular hypertrophy. Lastly, the colonoscopy findings and histopathology findings proving that overgrown tissue is present and malignant tumor forming in the colon.
Hi, I'm Xinyan. I will talk about the possible diagnosis in the patient. First and foremost, colonic adenocarcinoma. Colonoscopy identified a polypoid ulcerated mass in the ascending colon, confirmed as a moderately differentiated adenocarcinoma through histopathological analysis, characterized by 50 to 95% glandular formation. The malignancy likely accounts for the patient's systemic symptoms and elevated CEA levels. Secondly, pleural effusion. This is a condition involving fluid accumulation in the pleural space that impairs ventilation, which chest X-ray findings show cloudiness around the lungs. Abnormal arterial blood gases such as elevated partial pressure of carbon dioxide and reduced partial pressure of oxygen indicates lung damage. Thirdly, chronic kidney disease. This is evident from elevated creatinine and blood urea nitrogen level, likely resulting from secondary hypertension caused by fluid retention, increased vascular resistance, or systemic effects of congestive heart failure and malignancy. Besides hypercalcemia, a high level of calcium in blood of the patient can impair kidney filtration. Also, low albumin levels further support the diagnosis of kidney dysfunction. Fourthly, congestive heart failure. In this case, high blood pressure is present in the patient. Also, jugular vein distension is a hallmark of heart failure. Furthermore, lung crackers, leg swelling, shortness of breath, a displaced apical impulse, and elevated BNP level, which points towards biventricular heart failure. Lastly, this patient also has iron deficiency anemia, evident from low hemoglobin, low red blood cells indices such as hematocrit, MCV, MCH, and MCHC. This anemia leads to decreased oxygen carrying capacity, resulting in compensatory sinus tachycardia and cardiac dysfunction. Apart from that, iron deficiency anemia can be associated with thrombocytopenia, a low platelet count, which show on this patient. Chronic gastrointestinal blood loss activate the bone marrow to prioritize red blood cell production over platelets. This was evidenced by positive occur blood in the patient's stool. Moving on to the pathophysiology of colon carcinoma. First of all, genetic mutation. Mutation in the APC gene disrupt the WNT signaling pathway, a key regulator of cell proliferation in colorectal cancer. Normally, APC forms a complex that degrades beta-catenin, but mutation prevents this, leading to unchecked beta-catenin activity and the formation of benign adenomas. These adenomas can evolve into invasive carcinoma as additional mutation occurs. For example, KRAS mutations enhance proliferation signal, driving uncontrolled cell growth. Next, progression from adenoma to carcinoma. Colon cancer development begins with normal epithelial cells transforming into pre-malignant adenoma and progress to malignant carcinoma, while only about 5% of adenoma progress to carcinoma. As the adenoma grow, they evolve into advanced adenomas and may progress to colorectal cancer. Dysplastic changes within the adenoma play a critical role in their transformation into invasive carcinoma.
There are some laboratory investigations used to diagnose colonic carcinoma. First is fecal occult blood test. It is a diagnostic test that detects hidden blood in the stool. This test is commonly used for colorectal cancer screening, particularly in developed nations. Next is complete blood count. It is a blood test that determines the quantity and size of your red blood cells, hemoglobin, white blood cells, and platelets. A clinician can use it to monitor and diagnose conditions as well as assess the health of your immune systems. Infections, medicines, anemia, and cancer can all produce aberrant results. The third one is colonoscopy. Colonoscopy is the most common diagnostic test for studying the colon. It has the highest sensitivity among all the tests. Most colonoscopies allow doctors to examine 90 to 95% of the colon. The last one is histopathology. The histological findings from a biopsy taken during a colonoscopy confirm the diagnosis of well to moderately differentiate adenocarcinomas. The image shows glands of different sizes, each with hyperchromatic nuclear, abnormal nuclear cytoplasmic ratios, and mitomic figures, all of which are signs of cancerous cells. The histological examination confirms the diagnosis of colonic carcinoma.
My name is Suet. I'm going to explain the form of anemia in this patient and describe the etiology. In this case, several blood parameters are below their normal reference ranges, pointing to a diagnosis of microcytic hyperchromic anemia. The hemoglobin level is significantly low at 8.5 grams per deciliter, compared to the normal range of 11.6 to 15.6. Hemoglobin, a protein in red blood cells, transports oxygen to tissues. When levels are low, oxygen delivery is reduced, leading to fatigue and low energy. Hematocrit, which measures the percentage of blood made out of red blood cells, is also low at 28.2%, reflecting a reduced red blood cell count or size. The mean corpuscular volume, or MCV, is 72.3 femtoliters, indicating microcytosis, or smaller than normal red blood cells with reduced oxygen carrying capacity. Additionally, the mean corpuscular hemoglobin, or MCH, at 22.3 picograms suggests less hemoglobin per red blood cell, often due to iron deficiency anemia, as iron is essential for hemoglobin production. Lastly, the mean corpuscular hemoglobin concentration, or MCHC, is slightly below normal at 30.1 grams per deciliter. This indicates hypochromic red blood cells, which are pale and less effective at oxygen transport. These combined findings, along with the peripheral blood film, confirm the diagnosis of microcytic hyperchromic anemia. For the etiology of anemia, the underlying cause of the patient's anemia appears to be iron deficiency anemia, or IDA. A positive stool occult blood test points to gastrointestinal bleeding, most likely caused by colonic adenocarcinoma. Chronic blood loss depletes iron stores, making it the most common cause of microcytic hyperchromic anemia. Additionally, chronic diseases such as inflammation or malignancy, including colon cancer, may contribute to anemia of chronic disease, or ACD. However, in this case, blood loss and iron deficiency play a more significant role in the patient's condition. For the pathophysiology of cardiac failure, the patient's cardiac failure likely began with left-sided dysfunction caused by ischemic heart disease and recurrent transient heart attacks. This led to left ventricular damage, reducing pumping efficiency. As a result, blood backed up into pulmonary circulation, increasing pulmonary artery pressure. Over time, this progressed to right-sided heart failure. The right-sided heart failure caused systemic venous congestion with signs such as distended jugular veins, hepatomegaly, pitting edema, and ascites. Fluid buildup also led to swelling in the legs, abdomen, and genital area. The Renin-Angiotensin-Aldosterone system, or RAS, attempted to compensate by increasing fluid retention and vascular resistance. While this temporarily maintained blood pressure, it worsened fluid overload, causing symptoms like weakness and breathlessness. Diagnostic indicators include elevated B-type natriuretic peptide, or BNP, which reflects ventricular stretch due to fluid buildup. Hypoxia suggests pulmonary congestion or edema resulting from impaired cardiac output. The patient's heart failure is likely multifactorial, with several contributing conditions. First, long-standing ischemic heart disease and recurrent transient heart attacks cause myocardial damage, reducing the heart's contractility. Second, hypertension, with the patient's blood pressure at 165/90 mm of mercury, increases after load. This increases the strain on the left ventricle, worsening its dysfunction over time. Third, chronic anemia, indicated by a hemoglobin level of 8.5 grams per deciliter, increases cardiac workload as the heart compensates to meet the body's oxygen demands, further contributing to failure. Lastly, possible volume overload is suggested by the elevated BUN, also known as blood urea nitrogen, and creatinine levels, indicating the potential renal dysfunction. Fluid retention from this could exacerbate the patient's heart failure symptoms.
Drugs such as vasodilators, diuretics, aldosterone inhibitors, ACE inhibitors, digital glycosides, anticoagulants, beta blockers, and tranquilizers are used to treat congestive heart failure. This is used to control the blood pressure, enhance blood flow, and elevate the symptoms. Treatment is supported by lifestyle modification such as regulating fluid consumption, avoiding caffeine, and restricting salt. As a last resort, heart transplant may be required along with surgical treatments such as valve replacement, arterial operation, defibrillation implantation, or ventricular assist device. Telemonitoring, home visits, and professional nursing increase visibility to improve the treatment and lower readmission. With personalized therapies, hospitalization have decreased and results have improved. Early stage instances, polar removal via colonoscopy is part of the treatment, while for advanced cases, a partial colectomy is needed. Metastases are treated with surgery or localized therapy. In more severe situations, chemotherapy is used with radiation to relieve the symptoms. Chemotherapy is also used before the surgery to shrink the tumors and after the surgery to decrease the recurrence, while targeted medicines combine with chemotherapy that target the cancer cells in advanced stages. While robotic surgery facilitates recuperation, conventional resection is still essential, and results are improved by advancement in adjuvant and non-adjuvant therapy. Even in situations of metastatic disease, comprehensive therapies improve quality of life and survival rate. Treatment for chronic kidney disease includes drugs like statins to reduce cholesterol and lessen the risk of heart disease, diuretics to control the fluid retention, and ACE inhibitors to regulate the blood pressure. Reducing protein intake is part of dietary control to reduce the renal strain. When kidney fail in end-stage chronic kidney disease, dialysis is required to filter out the waste. Kidney transplant may be required, which needs immunosuppressive medicine for the rest of life. By improving outcomes, delaying progression, and stabilizing kidney function, early intervention, lifestyle modification, and routine monitoring lower the needs for dialysis or kidney transplant, while improving quality of life. As are drugs to increase the generation of red blood cells or control immune-related causes. Iron supplements, which are better absorbed when taken empty, vitamin C and vitamin B12 for B12 deficiency anemia are among the treatments for anemia. The initial line of treatment is oral iron therapy. For several instances of quick correction, intravenous iron is also an option. Customized care improves quality of life, lower healthcare requirements, and maximize results by raising hemoglobin levels. Addressing the root causes is necessary for long-term success in order to stop recurrence. The most likely reason for the patient increased BNP levels, edema, and breathing difficulties is left-sided heart failure, when ventricular tensions and fluid excess cause the generation of increased BNP. The diagnosis for polypoid ulcerated mass in the ascending colon are revealed by colonoscopy and histology. The appearance of an ulcerated mass strongly supports colorectal adenocarcinoma. The likely explanation for a positive to occur blood test is colorectal malignancy. It is because colorectal cancer often results in gastrointestinal blood loss that may be seen in stool.
In conclusion, this patient was diagnosed with colonic adenocarcinoma, CHF, CKD, and iron deficiency anemia. These conditions are interlinked with chronic GI blood loss leading to anemia and systemic congestion exacerbating cardiac and renal dysfunction. Management involves treating the cancer, stabilizing cardiac and renal functions, and addressing anemia. Thank you.